very lucky to be able to do these lessons with you. Today, we will be discussing kinesio taping applications in rehabilitation. So we'll first talk about, what is this stuff, right? And how does it work? I will give you a brief overview of some current evidence in the research literature about whether or not this is really effective for why we would use it. But most of our time, hopefully, will be learning how to use the tape and practicing on each other. Okay. And like Connie said, if you raise your hand, because you have any questions, please do so. So we'll answer questions along the way. You don't have to wait until the end to ask your question. Okay. So first off, what is this stuff, right? Kinesio taping can be, there's so many different brands. I use this Kinesio Tex Gold, is what I was trained to use through the training with the Kinesio Tape Association. But you have all these other brands now, and it looks like you have the TheraBand tape today. And this first original brand that kind of started the revolution of this type of taping was developed and founded in 1973 by a Japanese chiropractor. It wasn't until 1995 that it got brought to the United States. So it had been used in Japan for a long time. I would love to hear from you about when in Thailand it started to become used. The Kinesio Tex that I'll be using tonight is 100% cotton. I believe your TheraBand tape has a little spandex in it. But both the TheraBand tape that you have, as well as the Kinesio Tex that I have, they are latex free, okay? The Kinesio Tex has medical grade acrylic adhesive, so it sticks well. And the way that the tape is applied on the back is it's stretched 10% and then the paper gets put on, okay? Elasticity, how much it stretches, is about half of its resting. So if this is its resting, you get 50% more. So it's not super stretchy. The way I like to think about it is it's more of a short stretch, like a short stretch bandage, not a long stretch bandage. And it only stretches one way. It doesn't stretch multiple directions, okay? So the way that this tape was designed is to mimic the human skin. So it's flexible, it moves, it breathes, and it's very thin, right? Because it's similar to human skin. The nice thing with this is because it allows for full range of motion, a lot of people like it, especially athletes and dancers and people who have to move their body a lot like it because it doesn't restrict them. But a lot of other people find it very comfortable too, right? And then it breathes so you can get it wet and it'll dry. And because of that, and because it's so thin and gentle, you can wear it for multiple days. In the beginning, I usually tell my patients to leave it on for about a day. And if it feels still good, I'm okay having them leave it on for another day. So I usually let them know if this is your first time trying it, 1 or 2 days and then take it off, just to make sure your skin doesn't start to get itchy or anything like that. I will say that some patients have left it on for like 3 to 5 days, and they have no problems with that. So depending on the patient's skin sensitivity, you might be just informing them when to take it off. Obviously, if they get itchy or they start to feel kind of red or some kind of rash from the tape, then they should take it off right away. Don't leave it on, right? But for the most part, very few people have problems with the tape itself. The adhesive is fairly gentle. And the nice thing with this tape is that it's very adaptable. So you can use this tape for different types of body tissue. So there's a way to use the tape to improve lymphatic circulation. You can use it to help loosen the skin and the fascia, joints, muscles. You kind of have a lot of different ways to use the tape depending on how you put it on. So the question is, okay, well, it sounds great. How does it work, right? I'm going to play you a video. Let me know if it's hard to hear. But this explains the physiologic rationale of the tape.
The buildup of lymphatic and other bodily fluids can cause discomfort and inflammation. Kinesio tape alleviates discomfort and helps fluid drainage by microscopically lifting the skin. This lifting effect reduces pressure and inflammation and allows for fluids to flow in and out of the kinesio taping area.
Okay. So the key here is that when the tape is put on, it creates a lifting effect, okay? This is true with 50% or less of tension. So not a lot of tension on the tape, okay? Because if you have too much tension, something else happens. But if little bit of tension, it creates that lifting effect, okay? And this is what we use for the lymphatic, fascial, and space corrections and for muscle facilitation and inhibition. Now, because the tape stretches, you can stretch to more than 50% tension. And when you put the tape on with more tension, it creates compression. So this is why you can use the tape for different purposes. If you want compression and stabilization, you put lots of tension on the tape. Tension on the tape. Okay, so we're going to be practicing this so that you can get a feel for what that feels like. So what I'm going to have everybody do is you should try to have a piece of tape that you can play around with here. Okay, and what I'm going to have you do, and let me just set this up so I can see, is you're going to take your tape and you're going to tear it in the middle. So the paper is teared and you're holding on to the paper and the tape. So you don't touch the sticky part, okay? So take your square and tear it in the middle. And once you have it in the middle, like a Band-Aid, try to open it up. And the key is to practice, don't touch the sticky, okay? Don't touch the adhesive. And you're gonna open it up like a Band-Aid and make sure you're touching the paper, okay? So it looks like this, okay? And then you can feel, I have no tension on the tape, okay? And then now I'm gonna stretch. This is all the way tension, maximum tension, okay? So I have no tension, and then I have maximum tension. And you can see how when you have a lot of tension, the light goes through the tape, right? Because it's fabric. So as you have your tape, see if you can see what is 50%. So if this is maximum, this is 0, this is about 50%, okay? And the reason why this is important to feel your tape is because the amount of tension you're going to put on the tape will determine if you have lifting or if you have compression, right? And if you want compression, you need more than 50% tension. If you want lifting, you need less. So you kind of need to know where that 50% is. And 50% usually is just around the point when you can start to see through the tape a little bit, is about 50%, okay? So just practice no tension, 50% tension, 100% tension, right? No tension, what about 25? Then 50, 75 tension, then 100, right? So just practice getting used to your tape, because the TheraBand tape, you might feel like you can stretch more, right? So one of the differences in the brands is how much elasticity there is in the tape, okay? And I would suspect that the TheraBand tape might feel like it stretches more than what you see on my screen with my tape, okay? But that's okay, it just means you have to know how much stretch your tape feels like, okay? Questions about feeling the tension. It's a pretty important concept and something you just want to start to get very comfortable feeling on your own, okay? All right, So if I go back to, and I'm going to be bouncing between screen share and no screen share, so give me a moment here. So this is the key point. Less than 50% tension, remember it's lifting. More than 50% tension, it's compressing, okay? So that's going to determine how you apply the tape based on what you want. If you want lifting, it's less than 50. If you want compression, it's more than that. Okay, so now we're going to talk about the anatomy of the tape, okay? So this area right here where I'm stretching that you can see is black, that is the therapeutic region. The place where the tape is doing the work is called the therapeutic region. Where I'm holding on the paper right now, these are going to be my ends, okay? This is the end of the tape. The ends don't have any tension at all, okay? So the therapeutic region has the tension. The ends don't have any tension, okay? So that's one thing. I'm going to put this down, and then I'm going to show you another thing. Okay, so what we did was we practiced tearing the tape in the middle, right? And then we opened it up like a Band-Aid. The other way people use the tape, and you can take another piece of tape, you take one side, and you now have this anchor, right? So the anchor goes on the body first, okay? And I'll just practice here. So the anchor will go on the body, and then you peel the tape off of the therapeutic zone. Do that. So I have the therapeutic zone, right? I put that therapeutic zone down, and then now I have the tail. The tail is the end, okay? And the tail goes on with no tension. So you use the word end and tail when you have this situation where you have one side that you anchor, right? The therapeutic zone, and then the tail or the end, okay? If you're doing this and you're using it more like a Band-Aid, then you have these two ends, okay? They all kind of mean the same thing, but you might hear the words being used. So I just want to make sure that you've been familiar with it, okay? When you hear the word correction, that describes the type of method you're using for the tape. So why you're putting the tape on. With the original Kinesio taping methodology, there were 9 corrections. We're going to practice not all of them today, but half of them today, okay? And then if you hear the word block, it just means the back of the paper is divided so that you can measure out how much tape you have, okay? So that's just the paper backing on the tape. And then more terminology, you have different ways to cut the tape. So the eye strip is basically just one long piece of tape. So I'm going to have everybody cut an eye strip. On my tape, it has the blocks, right? So you can see 1 block, 2 block, 3 blocks. So cut about a 3-block piece of tape. So this is maybe about, I don't know, centimeters or so, okay? And this is an eye strip, okay, because it's just a letter I, right? The traditional kinesio taping method, you would round the corners, okay, because by rounding the corners, those ends don't peel off the body quicker. So you just kind of make it round. So this would be my eye strip, one long piece of tape, okay? Now, the tape is about, I don't know, 1 to 4 centimeters, something like that. So if you need smaller, then you can cut in half. And now you have a skinny eye strip, right? It's like half the width eye strip. So this one would look around the corners. So now I have a half width eye strip, right? So you can have a skinny eye strip or the regular width eye strip, but they're all called eye strips because there's just a letter I, okay? That's different from a Y strip. So now if we cut another piece of tape, we're gonna round the corners on the anchor, okay? The other side, we're gonna cut down the middle, okay? So we're gonna cut down the middle, and then you leave the anchor here. Now you have, really it's more like a V, not a Y, but we'll call it, it's called a Y strip. So this is a Y strip, okay? And then same thing, the traditional method would be to round the corners so that they don't peel off too quickly. So this would be your Y strip, okay? Looks like this, okay? So I'm gonna have everybody cut an eye strip, full width, okay? So it'll look like this. So here's your eye strip, and then you have a Y strip, okay? There is something called an X strip. We're not gonna cut one of those, but we're gonna practice cutting the fan strip. So take your eye strip, round the corners of your anchor, and then you make cuts. Now, on the Kinesio text tape, there's the boxes, but then there's also the vertical lines. So, and I'm gonna stop the screen share here. So on the vertical lines is what I usually follow. So I'll go, let's go this way. Here, and then cut the lines, and then you leave an anchor, about like this, okay? So there's always a little anchor, because that's gonna be where you start. And usually you make 4 cuts. So this is like, I always think of this like an octopus, but that only has 5 arms, not 8 arms, okay? So it'll be like this, right? So I made 4 cuts and now I have a fan, okay? So I'm gonna have people make 2 of these because you're gonna need 2 of these, okay? So take a moment and let's make 2 fan strips. So again, we round the corners on the anchor, okay? And then we cut the fan and we leave at least half a box for the anchor, okay? So it looks like this. So depending on how you use the tape, you're gonna make it cut differently. So it's a little bit of a crafty time. If you like crafts, you'll like doing kinesio taping, right? Okay, so you should have 2 fan strips. You should have 1 Y strip, right? And you should have 1 eye strip, okay? For those OTs in the room who are thinking about the orofacial weakness, I suggest, because we're gonna put the tape like this, your eye strips will be smaller, right? Because this is not a very long distance. So if you want to practice the orofacial weakness taping, I suggest you cut a little smaller, right? Because you only need about maybe a box and a half. So maybe like this size, right? So if that's something you want to try, you can just go ahead and practice cutting that now. Because we're going to be using all of this tape to practice our skills, okay? All right, and I'll give everybody a moment to ask any questions right now or have any questions about cutting the tape or the different shapes. Okay, so The next concept that is an important part of using the tape is the terminology that we use for the tension. So when we talk about paper off tension, that means that as you're putting the tape on, putting it on the skin. So the tape rolls off the paper and goes directly on the skin, okay? That's going to be about 10%, 15% tension. The tape is applied to the paper at 10%. So if you just take the tape and roll it onto the skin off the paper, you'll have 10% tension. And we're going to practice this when we practice the lymphatic correction and the muscle inhibition. Okay? Light tension is 15 to 25%. So that's not very much, right? Moderate here is 50 to 75, and then full tension is more than 75, and we really don't use that pretty much at all. Okay, most of it, even stabilization techniques, are going to be severe, so about 75, but never really pulling all the way max. Okay, documenting your taping technique, these are the types of terms you'll use. You'll say you used an eye strip for this correction, paper off tension, for example. So using the terminology can be helpful. Now we've come to tape is used, okay? So these are the 4 most common ways. This is going to be the way you'll use it most regularly, okay? So there's muscle facilitation. So when you want to use the tape to facilitate a weak muscle or to help wake up an inhibited muscle, you'll use a muscle facilitation correction, okay? So for example, if you have somebody who's having a hard time activating their lower trapezius and their muscle's not working, you can do a facilitation on that muscle, right? 2 is muscle inhibition. So this is the opposite. If you have a muscle or it's always really active, then you can do a muscle inhibition technique to calm that muscle down, right? So for example, if you have a patient with plantar fasciitis and their calf is always super duper tight, right? You can use the muscle inhibition to help relax and encourage that calf muscle to stop being so overactive, right? Lymphatic corrections used very frequently to decrease swelling or bruising. So this is great for anybody who has an acute injury or a sprain, somebody who's post-op, anyone who has excessive swelling or bruising from an injury or surgery, the lymphatic correction is very, very effective. And then the last correction that's commonly used is the mechanical correction. Sometimes we'll call it a positional correction. So this one is the stabilization one, right? So if you have a joint and you want to give it that cue to stay stable in place, you would use a mechanical correction. So for example, you have a patient who has a history of that anterior shoulder subluxation, and you want to provide that gentle cue to help the humeral head stay in the glenoid, right? Prevent it from subluxing. You could use a mechanical correction, okay? So these 4 are the ones that I most commonly use regularly with my patients. I mentioned that there were 9 total corrections in the Kinesio taping method. So here are the other ones that are used sometimes. And I want to mention them, but we won't have time to practice tonight. Although if you want to practice more of this, we can have another session on just these 5 too. So there's a tendon correction. So for example, so this would be to support a tendon that you some kind of strain of the biceps long head tendon. You can do a correction to help support that tendon. Same idea, ligament correction. So this one is ligamentous instability, and you want to provide a similar, support to help support that ligament, you can do that, such as at the medial knee after an MCL sprain. A fascial correction is to improve the fascial mobility. So if somebody has IT band syndrome and their IT band is very sticky, right? The IT band doesn't slide so well, you can do a fascial correction on it. Correction is the one that you use to really try to create that lifting effect, okay? So oftentimes this is used in areas where you have nerve entrapment. So for example, let's say pressure in that area, so you want to create that space correction, that lifting effect to help alleviate that pressure. And then the last correction is a functional correction. And this is actually used to almost provide that active assist of a muscle as it's being used in function. So a common area where this might be used is if somebody has a foot drop and you use the functional correction to provide a very gentle dorsiflexion assist, okay? It's not gonna fix the foot drop, but it can at least give the patient a little of that cue to know how to dorsiflex their foot while they walk. So these corrections are less commonly used. Of these, I use probably the fascial correction and the space correction a lot with some of my patients, but I have used all of these with good effect with my patients too. Okay, so current evidence, I'm gonna go through this section pretty quickly so we have more time to practice. But there have been some systematic reviews done on this, and if you look at these forest plots, basically favors kinesio taping is on the left of the vertical line, and then on the right is favors the other interventions. So you can see there's a trend towards favoring kinesio taping when it comes to chronic musculoskeletal pain. For chronic nonspecific low back pain, same idea. Things are favoring kinesio taping over other controls or other types of interventions. For rotator cuff disease, same thing. This is kind of trending. This was a Cochrane review. The one thing to note is all this, the red and the green and the yellow circles, those are risk of bias of the articles, and you can see not so much green, right? So one of the issues with a lot of these studies done related to kinesio taping is the risk of bias and the quality of the studies are low. So even though things are trending, sometimes some conclusions are hard to make. So in terms of orthopedic physical therapy, for chronic musculoskeletal conditions, Lim and Tay concluded that it doesn't establish superiority, but that there is some trend towards helping with pain relief. Same thing with rotator cuff disease. Gianola et al., this was a 2021 Cochrane review, said the certainty of evidence was low, but the evidence seems, so the evidence is demonstrating little effect or maybe no effect, okay? And a lot of this has to do with the quality of evidence as well as the increased risk of bias in a lot of the studies. For other patient populations, there is some positive effect being published related to reducing plantar flexor spasticity in patients after a stroke, and also found may be useful, again, maybe is the key word there, as an adjunctive therapy for working with children with motor impairments. Most of those children in that study had cerebral palsy, okay? So again, neurologic condition. And then related to sports performance, I pulled these pictures from different, from the internet. And so you can see all these different athletes, right? Tennis, beach volleyball, ice skating, basketball. So many athletes now are using kinesio taping. In the 2018 systematic review, found no specific convincing evidence for a lot of different types of sports. So in terms of the research evidence, things look like they support taping, but not very strongly, right? But when we think of evidence-based practice, Remember, research is just one part of evidence-based practice, and what we know from the research is it's low quality evidence, but the trend is towards being beneficial. And the research, just so you know, is a lot more robust in orthopedic and sports populations compared to other patient populations. What we know related to the patient values and preferences is a lot of patients want to try it, right? They see athletes getting it, they've heard about it, it's kind of trending, right? It's trendy, it's got different colors and patterns now. So, you know, many people want to try it, right? And many also say that it helps. And, you know, for me as a clinician, I kind of know my patients enough to know, oh, I think kinesio taping might help you. Do you want to try it, right? So, you know, you're selecting the patients that you think will benefit from it. I don't do it on everybody, right? So based on what I know, and I've been using kinesio taping. Yes, I got certified in 2009, so it's been, you know, over 10 years of using tape with patients. And it's very safe, right? You can use it across patient populations, across the lifespan. And a lot of my patients say that it definitely helps. And I definitely find that for patients who have a lot of symptoms or who are very acute in their injury, they might not be able to tolerate a lot of manual therapy or a lot of exercise or stretching, right? But they can tolerate the tape. So sometimes it's helpful to use early on when you might be limited with other types of interventions. And so the way I think about kinesio taping is that it's just one more tool in my toolbox, right? I don't use it on everybody. I select who I think might help, who might benefit from it, and who I think it will help. And then I also decide how I use it based on the patient. So it's all part of my clinical reasoning for why I use it. And so I wanted to give you this acute care example. So this is a patient. This is actually my husband. He had a total knee replacement a couple of years ago at OHSU. So that's an X-ray of his new knee, and this is what he looked like when he came home after his surgery. And you can see his right leg is much more swollen than his left leg. And so you can see the black tape is the lymphatic correction, right? I started his home therapy as his wife therapist, doing some lymphatic correction using the kinesio tape because he had a lot of bruising. So there was bruising all along the back of his knee from the tourniquet and all these things. So I did all this kinesio taping as part of his early rehab. And this is what his leg looks like after we take the tape off. So you can see how the area where the tape was on has less bruising and swelling, right? And so this is a nice, visual example of how the lymphatic correction can really be helpful in these early stages of rehabilitation with these post-operative patients. Okay, so now we get to practice, okay? But before we do that, are there any questions? Okay.
มีใครมีคำถามไหมคะ
Rico, this is Dr. Sushila. I would like to ask about the patient with chronic lymphedema. Can we use in those cases?
Yeah, great question. So if I misheard you, is whether we use the kinesio taping for patients with lymphedema. Is that was the question? Typically, no. Okay, and I'll tell you why. When we're working with patients with lymphedema, you know, they have the most common reason why they would have lymphedema is because they have lymph nodes removed or lymph nodes radiation therapy or other things, right? So their lymphatic system is not intact. So they, you know, that the clinical rationale for the lymphatic therapies are going to be to help to redirect the lymph fluid to other watershed areas in the body, right? So that's where your manual lymphatic drainage and other things come in. As part of your comprehensive lymphedema program, you would also be doing short stretch compression bandaging And if you're doing compression bandaging, then you don't need the tape because they're kind of canceling each other out, if you know what I mean, right? So the lymphatic correction on the kinesio taping is creating this lifting effect, right? But if you're adding short stretch bandaging on top of that and compressing, then you lose the lifting effect of the tape anyway. So it would be one or the other. And the comprehensive lymphedema program with the compression bandaging and the manual lymphatic drainage and the exercise, that has such good evidence for efficacy to decrease lymphedema that we typically don't use the kinesio taping for that. With that said, I have used, because I see patients with oncology diagnoses, so, I've worked with patients with lymphedema, and sometimes if they have a lot of scar tissue or fascial mobility restrictions, let's say from the radiation therapy or from surgery, and there's a lot of scar tissue or soft tissue mobility restrictions, you could potentially do a a fascial correction on that area with the kinesio taping, but you wouldn't bandage over it. That's the key, is if you're bandaging, you're not going to be putting tape in the same area. Great question. I hope I answered it okay.
Thank you.
Anyone else? Okay. So here's a few fundamental principles. When you start to put tape on people, clean, dry skin, and the tape doesn't stick to hairy people. So if you're putting it over a hairy area, just know that it might not stick very well, okay? And then the best practice is to use an alcohol wipe to remove lotion or oil or dirt from the skin. And so I just use an alcohol wipe over the area that is that we're going to tape, and then I let that dry, and then I put the tape on, okay? And I let my patients know why I'm wiping them down. And then if they have a lot of hair, I'll let them know, the tape won't stick to the hair. And I don't typically shave patients to put the tape on. I'll just think of other things in my toolbox to use instead. But a lot of the areas where I use it that isn't super hairy for most people, right? So it's usually okay. Remember, you don't put any tension on the anchors, okay? That technique of no tension on the anchors or on the tail is one of the reasons why it's so sensitive on the skin, because the end of the tape is not going to be pulling on the skin because there's no tension on it, right? It's just going to be resting on the skin. And that definitely does decrease the risk of skin irritation, okay? The position of the body when you put the tape on is always going to be in a stretched position, okay? So regardless of what type of taping you're doing, the area of the therapeutic zone will always be in a lengthened position. So you do need to know your muscle anatomy to make sure you know how to stretch that muscle, because it's going to be applied in a stretch position, okay? And then related to how you use the tape, this is the kind of tape where you set the tension and then you put it on the skin. You don't create tension and sort of like wrap it around, right? And you know how sometimes when you're using the athletic tape, you like anchor and then you pull and then, so you don't do any of that. With this one, it's like pull on the tape, even tension, and then put it down, right? So you're not trying to pull the tape around a body part, because then you'll lose the consistent tension on the tape. Okay. So key point with all of these techniques is you're using your clinical reasoning to decide how you're going to use the tape. Okay. So one of the problems I have with all of the YouTube videos and all this stuff on like how to tape is it's always related to the clinical problem, right? Like, for example, this is the taping you do for this problem, right? And the way that I like to use the tape is more about the clinical problem solving, right? So, I think your neck hurts because this muscle is too tight and this muscle is too weak. So we're going to do a taping to help relax the tight muscle and facilitate the weak muscle, right? So the reason why I'm putting the tape is always linked to the rationale, right? The clinical reasoning. And so we're going to practice these 4 skills, and we're not going to do the other 5. We could always do that another time. Okay. So muscle facilitation. It's going to be done to facilitate a weak muscle. Usually you use an eye strip. So we're going to, I'm going to have you cut an eye strip if you don't have one. Otherwise, you're going to take the eye strip you have, right? The muscle is positioned into a stretch position, and the therapeutic zone has light to moderate tension, okay? When you do muscle facilitation, the distal anchor is near the insertion, okay? So you start the tape proximal, and then you go distal, okay? So again, the reasoning is because the tape pulls back. It's got recoil from the elasticity. So if you start the tape proximal, stretch the tape, and then put the tape down, the tape's going to want to recoil proximally towards the insertion. That's kind of how it creates that facilitation effect, okay? So I'm going to stop my screen share, and I'm going to show you what that might look like, okay? And I'm going to use just my arm. So let's say I want to facilitate my wrist extensors, right? So that means that I'm going to use my eye strip, okay? And let me I'll cut a little bit longer one. So I have this. I'm going to use my eye strip. And I'm going to start the anchor proximal, right, at the insertion of the wrist extensors. And there are a lot of wrist extensors, so I'm just going to go anchor here, right? So now I have an anchor. That's my anchor. I'm going to put it proximal to my wrist extensors. There's no tension on that anchor, right? And then I rub it to make sure the adhesive is sticking to my skin, create a little heat. Okay, so now I have the anchor on my skin, but the rest of the tape still has the paper on it, okay? So if I'm facilitating, I'm going light tension. So I'm going to open up the therapeutic zone, okay, there. Okay, the muscle has to be on stretch. So I gotta flex my wrist to put my wrist extensors on stretch. And then 25 to 50% tension over the muscle belly. Okay, put that down. And then no tension on the tail. I take the paper off, no tension, and then I put it down on the distal side of the muscle. And then I rub it on to activate the adhesive. Okay, so now this is pulling towards the insertion, and that's how it's helping facilitate my muscle. Okay. If you were going to use this for somebody who has weak masseter, let's say they have a weak masseter, right? So they have weakness in this muscle, and you want to help facilitate it, right? You would use a little guy, right? A little eye strip, because it's just going to go like this, right? So then you would take a little anchor, so like this, pull and tear, right? If you think about how masseter works, your proximal or your origin is going to be on this side, right? So you're going to put this down on your zygomatic arch, right? You're going to peel the tape. And sorry, I can't see. Okay, there we go. Muscle has to be on stretch. So I gotta, and then I'm gonna put the tape down with light tension. So stretch the muscle, and then no tension on the tail before I put it down. So now this tape is helping to facilitate the jaw closer muscle. And you probably would, I don't know, depending on the patient, you might do both sides. Okay, so this is what it would look like. So that's facilitation. Okay. Any questions before we try inhibition? Okay. So with muscle inhibition, remember this is to relax an overactive muscle. We're going to practice with an eye strip. Okay. There's going to be no tension, and you start it on the distal side near the insertion. Okay. The muscle still gets put on stretch, but the difference is now this is paper off tension. So very minimal tension. Okay. And then the distal anchor is going to be near the origin. So facilitation, the tape starts proximal and it goes distal. For inhibition, the tape starts distal and then it goes proximal. Okay? So we're going to give this a try. Okay? And let me stop the share here. Does anybody have a request on where we try the inhibition? Where someplace where you want to see that I might be able to demonstrate?
The inhibition can be help in spasticity or rigidity in Parkinson's.
Yeah, so exactly. So sometimes you'll see it used in, in the study with chronic stroke, where the patients had spasticity and increased tone in the plantar flexors, you could use this technique for sure. So actually, let me do something real quick. I have a t-shirt underneath, so excuse me. Well, we'll take this off, so then I'm going to show you on my arm, okay? So let's imagine somebody has a lot of flexor tone, right? They're here. And you want to see if you can relax the bicep, right? So you're going to have the bicep here, and you'll cut a piece of tape for the bicep. And then for this one, remember the anchor starts distal, so on the insertion. So I'm going to take the anchor here, right? I'm going to put it on the distal side here, okay? The muscle is on stretch. So ideally, I would have my shoulder extended and my elbow extended so that the biceps long head is also on stretch, okay? And this is where it's important to know the anatomy well enough to know what the optimal stretch position is. From here, taper off tension looks like this. As you take the paper off, you're laying the tape on the skin, okay? And then the last piece, no tension. So at the end, remember, no tension on the tail. So you pull the tape all the way off, and then you put the tail down, and then you rub it in. So this tape started down here, taper off tension. This tape started up here, light tension, okay? So they look the same, right? Like, I says, oh, I just have an eye strip on my arm. But where the tape started, where the tape ended, and how much tension is on the tape is different. So this one is doing muscle facilitation. This one is doing muscle inhibition, okay? So that's why you can't just look at a picture and know what to do, right, with the taping, because you have to know where it started, where it ended, how much tension, all of those things, okay? So this might be a biceps inhibition. This is wrist extensor facilitation. This is masseter facilitation, okay? All right, so that's muscle inhibition, muscle facilitation, and now we have that lymphatic correction, okay? So again, this is used more for acute injury or bruising, and this is where you need your 2 fan strips, okay? So we're going to practice putting this on. The skin is still stretched as much as you can. So keep in mind, if you have an acute injury, it might be hard to position into a full stretch position, but you just do the best you can. And again, this is going to be paper off tension. So you're going to, this one is again, just like the inhibition, it's paper off. And then what you want to do is try to create that crisscross pattern. So if we go back and let me just show you the picture from the total knee again. What I'll show you here is an example of how we did the lymphatic correction. So in the knee, you have the anchor, right? And then the fan spreads out. And you try to crisscross because you're trying to cover as much surface area as possible. So I did one section on the lower leg and then one section up at the thigh. So when you see the pattern, you see the crisscrossing of where the bruising got better, right? So for our demonstration, I'm going to do my knee. Okay, so here we go. Let me lower this down. And then if I have my knee here, let's say that I fell, I have anterior knee swelling, right? And it hurts and it's bruised. So I'm gonna do this taping. So I have my 2 fans already cut out, right? So the way this works is for the paper, you have to pull. Each fan has to have its separate paper, right? So you're gonna pull like this. That way, you have the anchor exposed, but the tails still have the paper on, okay? So if the swelling is in the front of my knee, here, right, the anchor has to be to the closest lymph node area. So if it's here, I'm gonna try to get into some of the lymph nodes in the back of my knee. So I'm gonna start with my knee a little straight so that I can apply the anchor close to those popliteal lymph nodes, okay? And I'm gonna rub that in. And then I'm gonna bend the knee so I can stretch the area that's gonna be taped. And then this is going to be paper off tension. So I take each strip individually and I make a fan on the skin going down over the area of swelling. So here I have to straighten first to get the skin to stretch, to get the skin a little bit more tight, okay? Of this, you're gonna have to change the position depending on where you're taping, okay? So these are getting kind of into posterior knee, so I need to stretch that area. Okay, so if this is on one side of my knee, the other fan is gonna be on the other side. So I'm gonna do the same thing here, where I pull and get the all released from the anchor here. So it looks like this. And then this one's gonna be on the other side of my knee, okay? So the anchor goes back here. And then same thing, I'm going to taper off tension with the knee bent. And then I'm gonna try to crisscross, right? So you make a little crisscross pattern on the knee. And then straight. So this one takes a little more time because there's so many strips. But you can see from the pictures from the knee replacement, it does work pretty good, right? So one here. And then you have the crisscross on the knee, okay? Questions about that one? Anyone? So that would be the lymphatic correction. The anchors start on the proximal side, and then you crisscross with paper off tension. Okay? Okay. And again, you can use it on any body part that has swelling or bruising from an injury. Okay. Okay. And then the last one is the mechanical correction that we'll demonstrate today. So the mechanical correction, so this one is the one to facilitate optimal positioning, right? So this one is a nice one to support a joint that wants to move around too much, right? So this one is usually done with the eye strip, okay? And this is where you open it up like a Band-Aid, okay? The joint is positioned in the optimal position, and then this is when you get to put severe tension on, okay? And you set the tape in to that target area with pressure to facilitate the correction, okay? So with this tape, you need 2 hands to do it. So I'm gonna have to pick a body, like my leg, and I'm gonna show you a nice positional or mechanical correction for the patellofemoral joint, okay? So let me show you that one next. So for this one, I'm gonna do my other knee because my left knee has the lymphatic correction. So we'll do the right knee for the mechanical correction. So let's say that I have patellofemoral joint syndrome and this kneecap likes to slide around a lot, right? And because let's say I have a lot of internal rotation of the femur, it always wants to slide out that way. So I want to push it over to the inside. So it's basically doing a medial patellar glide on the knee, okay? So here's, I'm gonna keep the kneecap over to the medial side to avoid the lateral subluxation of the patella. So I have my eye strip. I'm gonna open it up in the middle like a Band-Aid, okay? It's gonna look like this. Right, so this is gonna be the therapeutic zone. For my kneecap, I'm gonna make sure that it's tracking and it's where I want it to be, right? And then this area is on a little stretch, right? So remember, we want the therapeutic zone on stretch. I'm gonna pull on the tape for about that. This is 50, this is 75. So I'm putting 75% tension on the tape, and then I'm giving a medial glide on the knee with the tape, okay? And then I let go, no tension on either end of the tape, okay? So now this tape is helping to keep the knee going towards the medial side, okay? So you can use this on the glenohumeral joint if you need to push that glenohumeral joint back. I've used this also okay, so that was mechanical correction. And I know out of time, Connie, but I hope that was good demonstration.
It was amazing. I learned so much, and I'm not a PT or an OT. But I think Dr. Sushila, Dr. Noriko needs to come to Thailand.
I agree.
Thank you so much once again. Do you have any other questions, Dr. Sushila, or any other?
I think the taping will help the stroke patient who have the shoulder downward subluxation in the weak side.
Yeah, so for the shoulder subluxation post-stroke, I would definitely encourage the muscle facilitation for all of the deltoid muscle group. For that one, the Y strip comes in very handy. So the way this works, I'll show you real quick here. If you have the time still, what you would do is do your Y strip. So you take the anchor off. You put the anchor on the top of the shoulder by the acromion, okay? This front one is going to facilitate this anterior deltoid. So what you would do is pull the tape here. The arm goes into extension so that the anterior deltoid is on stretch. You have 50% tension on the tape, and you follow the muscle belly of the deltoid to the insertion on the brachium or the humerus. This one is going to be for your posterior deltoid. This one, I usually have the patients come across, 50% tension on the tape to facilitate that, no tension on the tail. And then from there, you would have your last strip would be for the lateral deltoid. So for that one, you would go again up at the top, this time with an I strip, and then 50% tension straight down the side of the arm, and then no tension on the tail. So you end up with a facilitation anterior, posterior, and lateral on the deltoid muscle group to help try to get the deltoid to wake up and keep the shoulder in. Yeah. So that I also use in patients who have rotator cuff problems, degenerative rotator cuff tears, where you really need to get the deltoid working more to help compensate for the lack of the supraspinatus. And I found that this technique works pretty well for that.
Thank you I think yeah อาจารย์คะอาจารย์มีคำถามอีกไหมคะ
ไม่กล้ามีแล้วค่ะ
Okay, thank you so much for today's. We were looking forward to see you sometime or in Thailand.
Yes, come to Portland, or yes, and we can practice more taping.
Sawadika. Thank you so much.
Thank you so much, everybody.
Thank you so much. A lot of learning today.
Have a good day.
Thank you so much, Connie, Noriko. We appreciate that.
Bye. And then, Connie, if you can just make sure they have access to the slides, the PDF slide deck and the articles. I think there are a lot of people who got the shared folder, but
Yeah.
if everybody else can have it too.
That sounds great.
We have shared the slide to all the staff already.
Oh, great. Thank you so much.
Thank you. Goodbye. Have a nice night.
Have a good day.
Good night.